We've had some amazing talks today about genetics, about looking at cleft palate, by looking at ophthalmology, and I'm going to pivot slightly into looking at some of the more musculoskeletal side in diagnosing Stickler syndrome. So first of all, who am I? My name's Robert. I'm a pediatric trainee. When I search for pediatric trainee pictures, I find something like this, and I have never seen a kid take a throat swab so politely. Usually, my patients are more like that. And my special interest that I am training in is rheumatology, in things like hypermobility, which is how I've become interested in Stickler syndrome. And as of this year, I'm a clinical research fellow with ACT, so part of my time is dedicated to research. And specifically, that will be into Stickler syndrome. There are a lot of difficulties with Stickler syndrome, as you all very well know from your personal experience, around, in my opinion, some of the hardest bits: diagnosis and sight loss. And finding better paths towards diagnosing Stickler syndrome is essential. So many of the lovely people I've talked to today have talked about their journey to diagnosis, which was littered with sort of partial presentations to hospital, being seen for one thing, but not having that full picture put together. And unfortunately, that is the case with a lot of rare syndromes. Because any rare genetic disease has that lack of awareness, because it's not common. It's not something that doctors see every day, nurses see every day, healthcare specialists see every day. And our diagnoses are very much based on pattern recognition. When you see your child that comes in with their snotty nose and their fever, you say, it's probably a virus, it's okay. Come back in if it keeps getting worse, but it's probably going to be all right. Whereas most people are not well equipped to say, actually, short-sightedness with joint hypermobility, with hearing loss, with the cleft palate are part of this Stickler syndrome. And because of that lack of awareness, the symptoms aren't recognized and the diagnosis gets missed, which then makes it a rare syndrome because nobody gets diagnosed with it. And this cycle is what the biggest difficulty, I suppose, with rare diseases really is. You have to break that cycle. And there's a lot of work that goes into education. But even that itself is a lottery. We see patients here that may have been picked up because they happen to have a doctor or an optician or someone else that had worked with Stickler patients before and therefore was able to make that diagnosis. But for the vast majority of healthcare professionals, they don't know about these sort of conditions. And trying to educate them, yes, is one way, but you'll still have many people that won't understand why these different symptoms actually mean a bigger picture. So is there other places we can intervene where we don't even actually need people to necessarily recognize all of these separate features, but to be able to start to pick out smaller things and identify, well, actually, could this be part of a larger genetic presentation? And that's where often screening tools come in. Screening tools can pick out more individual symptoms and give you risk scores and help guide where people who needs to be investigated further for certain syndromes. And to use a screening tool, if you've got a list of different symptoms that you need to look out for, you don't need to understand the condition, you don't need to understand Stickler syndrome very well, but if you've been given the screening tool and told everyone with the cleft palate needs to come in and have this, then you can still pick up new presentations. And there's a lot of work that the team have already done with trying to get people who come in with retinal detachment getting screened for Stickler syndrome. In Edinburgh at the moment, the cleft palate team there are very keen on getting patients with new cleft palate presentations to have genetic tests for Stickler syndrome. And again, that's another way where these patients can be identified much sooner. My interests in my research that I'm doing over the next couple of years will be looking at a different condition, something called Perthes disease. So Perthes is another rare disease. It's even slightly rarer than Stickler syndrome, but much more well known about amongst clinicians for whatever reason. And it's a breakdown of the hip joint. Your hip has this lovely sort of smooth head to it, which fits nicely into your ball and socket joint. And very cleverly, whenever nature designed the hip, they made these arteries which come back. But in kids, they made this main artery, which supplies the whole of the head of the hip. Now you can imagine if a hip joint's moving around, blocking that artery or doing some damage to it isn't too difficult. That's one of the theories that's being proposed for Perthes, but actually it's not really been fully proven. So we're not actually even sure how this disease happens. But what does happen is that you get breakdown of that hip joint. This is a great contrast, so don't worry if you can't see, but you've got smooth sort of hip joint here, and this one actually quite flattened, quite spread out, more degenerate. Perthes disease is something that happens in kids. Usually the age of presentation is around 4 to 7 years old. Usually before you're 10, you'd come to an orthopedic clinic with this suspected condition. And the signs and symptoms might be hip pain, might be some joint changes when you do the x-ray, and might be some limp and difficulty with mobility, which I think will be quite a familiar picture to a lot of you in terms of how you might be infected with your joints. Difficulties with pain, difficulties with mobility, without really a clear cause is quite a similar presentation to Stickler syndrome. And whether it is because Perthes disease happens in Stickler and this process of breakdown the hip happens, or because the symptoms sound like it and this other disease is more well known about than Stickler syndrome, we found a number of patients in the Cambridge cohort from across the UK and Ireland that had this diagnosis of Perthes disease way back in the past. And of those, many had suffered from sight loss, and many had ended up having blindness or sight loss as a result of their retinal detachment, which had happened. So 1% of our patients isn't a massive amount, but as we know, when we diagnose one individual, we can diagnose entire families. We can find out about generations who also have been suffering from Stickler syndrome and the associated difficulties. And as we will talk about later, and Martin will talk about later, is that we have treatments that can help prevent retinal detachment. For Perthes disease, because it's happening in that first decade and the average age of onset, not obviously with all patients, but the average age is in that second or third decade, we're actually, if we were able to find Stickler patients in this Perthes disease population, we'd be identifying them before they had the detachment. We'd be able then to, if we were identifying them, to talk about prophylactic treatments or other things which are going to prevent that detachment. So then the real question is, if I went and threw my big net over a group of Perthes disease patients, would I actually find any people with Stickler syndrome? We have developed a screening tool, first of all, to see if when we give that to Perthes disease patients, do they have some of these features? Thomas talked earlier about the different main parts of the Stickler syndrome, such as the eyes, cleft palate, hearing loss, difficulties with joints, and we've tried to capture that into our screening tool. I am still to do some more research on exactly how we're going to properly score it and decide which things are more important or less important to creating a high-risk patient that would require genetic screening, because obviously Stickler syndrome is so varied. We need to really think about how we pick people up. But with that screening tool, we can take it and apply it. So we've got a team in Liverpool who are doing a separate trial at the moment with surgery versus non-surgery treatment of Perthes disease. And we can give that screening tool to that population and see if people come back as high risk. Do we have a lot of patients that are looking like they could potentially have Stickler syndrome underlying? And once we've got that high and low risk group, then we can apply the genetic test for Stickler syndrome and see if we're catching new diagnoses that have presented in this way, but we haven't identified because they haven't been picked up by local teams, or they haven't developed those other symptoms like the retinal detachment, or the hearing loss is present but perhaps not severe, or they've got some myopia but it hasn't been identified as part of that Stickler syndrome phenotype. And then, of course, if we do diagnose new patients, we can give them the support and bring them in to our centre for further support for all of the many teams that can support them. This research hopefully could lead to earlier diagnosis. And because of that, could prevent retinal detachment and many of the other things that happen in Stickler syndrome. If we've already had some really interesting talks about hearing, about balance research that we're doing, about there's going to be a talk about musculoskeletal side of things as well. So all of these things can really benefit from early intervention and treatments, and by diagnosing earlier, we have a chance to offer those things. And actually, if we did develop a model of screening in this disease cohort, in this Perthes disease cohort, then we could spread that to other parts of the UK and use it elsewhere, which means that actually we're not just casting our nets in sort of one area where there is a person who's interested in sticklers. We're able to then use it across the UK. People don't have to be experts in Stickler syndrome to say whether you have a family history of retinal detachment and use that screening tool. And if we then have more people being screened, more people being diagnosed, then hopefully we raise awareness as well. There are a few little caveats to this. The patients that we find thus far are all type 1 Stickler syndrome. It's the classic case of having a rare diagnosis of the rare disease means it's harder to find those sort of research opportunities and to find bodies of patients that might be able to be identified with Stickler. And of course, we might not find any in this cohort. We don't actually know. This is a new bit of research that we're trying out to see if we can identify people, but we might not find any. And at the moment, it's a very specific group. It's just in that people with Perthes disease populations. But if it does work, it means it can be applied to other diagnoses that people with Stickler syndrome might have been given before they were given their actual proper diagnosis. That's essentially my talk for the afternoon. So it's not a very long one, it's quite speedy. So I'm more than happy to take any questions, or if we are running out of time, we can bring them back at the end. I don't mind.
Are you around later for our Q&A
panel?
I'll
be around later.
Brilliant. If you could just note down any questions for Robert, that would be fabulous. Thank you very much.
No worries.